Now it's time to introduce the second speaker, Professor Dominique Fletcher from the University of Paris. You are head of the Department of Anesthesiology and Pain Unit, and the title of your lecture is Acupan in postoperative multimodal analgesia. Please.
Thank you, Frédéric. It's my pleasure to be part of this web conference. So, in fact, I will discuss now about specifically the role of Acupan in multimodal analgesia. I will go through three aspects of the question. First, the mechanism of the action of Acupan and the efficacy in postoperative pain, focusing specifically on the benefit to add Acupan in the strategy of pain control. And finally, I will try to give a sort of recommendation concerning how we should use Acupan for surgical patients. So first, concerning mechanism of action, nefopam has a central action on the central nervous system. It has an action both at the spinal level and the supraspinal level. It's not interfering with opioid receptor. It has some data both in clinical research and animal research showing that there is some action of Acupan on the central nervous system sensitization, so it can be qualified as an anti-hyperalgesic drug. And there is some interaction which can be useful for us, specifically the synergy with the non-steroidal anti-inflammatory drugs. So we'll go in detail on this aspect. So the first one, the mechanism of action. There is a central action of nefopam. It's inhibiting the monoamine reuptake, and in fact it's potentialing the inhibition of pain pathway, and it's acting both on the brain at this level, and it's acting also on the spinal cord. And basically its inhibition on the monoamine recapture is reinforcing the inhibitory control of the nociceptive message. There is no interaction at all with opioid, and these histograms are showing the impact on nefopam in animal. You have different dose and different way of administration of nefopam. You have here this histogram in gray is showing the control group with the level of pain induced by the stimulation, and when you administer nefopam in blue, you have a decrease in the intensity of pain, showing the analgesic effect of nefopam, and in orange here you have the combination of nefopam and the antagonist naloxone, and you see that there is no difference when you give nefopam alone or nefopam with naloxone, and it's confirming that nefopam has no interaction with opioid to produce its analgesia. When you look at hyperalgesia, just to remind you, hyperalgesia is a concept concerning the sensitization of central nervous system, and this hyperalgesia can be measured in surgical patients, and that's what was done by Philippe Richebé in this study in patients going through sternotomy, and he was measuring the severity of allodynia around the wound here at different level, and you have here the time course of this hyperalgesia during 7 days after surgery. In three groups, the groups of control groups, where you have the decrease in the pain threshold describing this allodynia after surgery, and in two groups receiving nefopam either before surgery or at the end of surgery, and you see basically that for the first or second day after surgery, there was a limitation of this hyperalgesia by nefopam. As I said, there is an interesting synergy between non-steroidal and nefopam. Non-steroidal, as Gilles has previously described, is an important analgesic also for postoperative pain control. And you have here a study in surgical patients describing the dose required to have an analgesic impact, either with nefopam alone, with ketoprofen alone, or with the combination of the two drugs. And here you have what is called an isobalographic representation describing the type of interaction between the two drugs. You see here the result of this of the analysis of this interaction, and you see that the dose of the combination nefopam and ketoprofen necessary to obtain the analgesic effect is much lower than the line of additivity, which is here, describing clearly a synergy. So it means that when you combine nefopam with ketoprofen, you obtain a more intense analgesic effect. So you see that through the mechanism of Acupan, you have multiple action, and it's basically a central acting non-opioid analgesic with some also anti-hyperalgesic effect. So what about the efficacy? I will shortly repeat some of the concepts that Gilles has already nicely described. First, the improvement of analgesia, because the idea to combine Acupan with other analgesic, including opioid, is to obtain this morphine-sparing effect, so the reduction of the dose of opioid necessary to control the pain. It's also potentially to reduce the pain intensity. It's also to reduce the opioid-related side effects, especially postoperative nausea and vomiting and sedation. And it's an agreement in the literature that when you obtain a reduction of about 10 milligrams for 24 hours of treatment with opioid, you can expect some reduction in side effects, nausea or sedation. And of course, there is the other side, which is potentially the addition of new side effects. For example, when you use non-steroidal, you can increase the risk of bleeding or gastrointestinal toxicity or cardiac problem. And each addition of a new analgesic can be responsible of additional side effects. And specifically, there is also the impact on hyperalgesia. The leader for anti-hyperalgesic drug is ketamine, which is not the case, for example, for drugs like non-steroidal. As we discussed before, Acupan is also considered of a slightly anti-hyperalgesic drug. So what about the global effect of Acupan when it's combined with opioid in major surgery? That's the largest published study describing the impact of nefopam in major orthopedic surgery. It's total hip arthroplasty. There was 200 patients included in this study, and the comparison was between nefopam 20 milligrams every 4 hours to a placebo, and the patient will follow up for 24 hours. And you have here the intensity of pain in black in the group receiving nefopam, in white in the group receiving a placebo. And you see that the clinical impact on pain was limited to the first hour after surgery, but there was on the other side this morphine-sparing effect, which was significant, around 22%, with no impact of this morphine-sparing effect on sedation and nausea. When you look at the impact of nefopam on the use of opioid, and there was this meta-analysis published looking at the morphine-sparing effect of nefopam when it's compared to a placebo, you see that there was a reduction of about 13 milligrams of morphine for 24 hours, and this morphine-sparing effect was around 30% compared to a placebo. You can, of course, use nefopam either combined with opioid with PCA or oral administration, but some authors have described also the direct combination of opioid and nefopam directly in a PCA pump. That was done in this study after laparotomy, and you have a PCA which was a mixture of fentanyl, 25 micrograms per ml, and nefopam, 2.4 milligrams per ml, and patients were receiving, when they were asking for a bolus, both nefopam and opioid. And you see here the evolution of the pain level for 24 hours, and you see that the patient receiving the combination of nefopam and fentanyl had a lower pain intensity for 24 hours compared to patient receiving only the opioid. So what is the morphine-sparing effect of nefopam combined to all other possibilities we have available with opioid? That's a study that colleague Valeria Martinez has performed. It's what we call a network meta-analysis. It means that it's analyzing a lot of studies. You can see here that the number of studies including in this network meta-analysis. And you have here different solutions, either one non-opioid analgesic, paracetamol, nefopam, tramadol, and all this amount of study, the average morphine-sparing effect was around 6 milligrams. This type of single administration of non-steroidal anti-COX-2 or alpha-2 agonist, it's around 12 milligrams of morphine-sparing effect for 24 hours. And interestingly, when you look at combination of non-opioid analgesic, it means non-steroidal and paracetamol, non-steroidal and nefopam, or paracetamol and nefopam. The morphine-sparing effect is quite increased, around 20 milligrams for 24 hours. A specific action of nefopam, which is quite different from other drugs, it's the impact on thermoregulation. We know that surgical patients can have a decrease in temperature after surgery. They can have shivering to control this hypothermia, and that can be both a medical problem but also a source of discomfort for the patient. And interestingly, nefopam is the most interesting drug to control the shivering. You have here a comparison of different types of drugs, looking at the impact on shivering, and you see that nefopam is the leader on this impact. So when you prescribe nefopam, basically you have analgesic effect, anti-hyperalgesic effect potentially, and also this third action on shivering. Of course, there is side effects, and you have to know these side effects before prescribing this treatment. Nefopam can be responsible of nausea and vomiting, some sweating, which is quite specific to this drug and related to this action on thermoregulation I just discussed about. Some local pain on the site of injection, dizziness, and also, more specifically, tachycardia, urinary retention, dry mouth, or increase in intraocular pressure in glaucoma. So what is good news is that we can control partially this side effect basically by reducing the speed of injection, either by giving slowly the drug on 30 to 60 minutes or giving a continuous infusion. It's been shown in volunteers that it can reduce the dizziness and the tachycardia. So how we should use Acupan, knowing now what are the mechanisms of action and the efficacy which was described in surgical patients. First, we have this sort of potential drug we can mix together. Gilles has nicely described that, both analgesic, paracetamol, non-steroidal Acupan, and anti-hyperalgesic, which have a different type of action because they are responsible of more prolonged action and potentially control of hyperalgesia. The recommendation of the French Society of Anesthesia was this one in 2008. Nefopam use in combination with opioids should probably be recommended after surgery, associated with moderate to severe pain. However, it should be used with caution in patients with heart disease because of the risk of tachycardia. So that was identified as the main risk related to prescription of Acupan. There is, of course, contraindication. People have to know about it also. It's not allowed in children due to absence of clinical data. It's not allowed in case of a recent convulsion of past history of convulsive disorder. It's not allowed in case of erythropostatic disorder with the risk of urinary retention. There's the problem of acute angle glaucoma and also pregnancy and lactation due also to limited clinical data. There is some precaution of use for in case of patient with hepatic insufficiency, with patient which can be exposed to tachycardia due to abnormal rate or risk of tachycardia for coronary insufficiency. And the good news is that on the other hand, nefopam is not contraindicated in case of renal insufficiency, and we have more and more patients with renal insufficiency. So in this case, nefopam is a good indication. The posology, the idea is to obtain rapidly a peak effect. The peak effect can be obtained when the drug is administered during surgery, and 20 milligrams at least 1 hour before the end of surgery, so the patient can have the analgesia when he is recovering from anesthesia. And to continue this analgesia after surgery, the target is to give 80 to 120 milligrams over 24 hours, and you can make your choice between this continuous infusion, 20 milligrams over 30 to 60 minutes, a continuous infusion, or as described previously, potentially some people mixed it directly with opioid in PCA. So in conclusion, this Acupan is totally part of multimodal analgesia. It means that it has to be combined with either analgesic or anti-hyperalgesic drug. We have to remember that nefopam combined with non-steroidal is quite synergic and quite helpful. We have also to remember that B therapy combining non-steroidal nefopam or paracetamol nefopam has an important impact on morphine-sparing effect. We've seen 20 milligrams reduction over 24 hours. That can be combined also with ketamine during surgery. And opioid will this time be prescribed as rescue. All this treatment has to be, of course, settled in adequate organization with surgery-based protocol and quality improvement. Thank you.
Thank you, Dominique. This excellent presentation. The session is open to question. I have a few questions about pediatrics, but you answered the question. Children below 15 years old is a contraindication
Sure,
in France.
because there is no data in children and there is no marketing authorization.
Okay, absolutely. Another question about preemptive analgesia.
In fact, there is no benefit to give the Acupan before surgery. I've just shown the study by Philippe Richebé in sternotomy, and he tried to give Acupan before surgery or at the end of surgery, and basically the clinical impact was the same. So there is no interest to give it before incision or before surgery. There is just a recommendation, as I said, to give it 1 hour before the end of surgery so the patient can have the analgesic effect before he wakes up.
Okay, excellent. And what about severe side effects?
Severe side effect, I would focus rather on tachycardia, which is the more problematic side effects. When you look at other side effects like nausea, vomiting, or sweating, sweating can be disturbing because it's not frequent to have this side effect, and people can think that patient has respiratory problem. It can be impressive, but it's not important or problematic side effect. But tachycardia can be a problem in patients, especially with coronary artery disease.
Do you have any data about allergy?
No, not that I'm aware.
No data. Okay. And another question about oral administration of Acupan.
Yeah, it's quite popular in France. There is no marketing authorization to use it by mouth. We know that when Acupan is administered by mouth with the ampule, it's giving a metabolite which is called desmethylnefopam. We don't know exactly if desmethylnefopam is analgesic, but clinically a lot of people prescribe it by mouth.
Okay, thank you. And Acupan regional anesthesia?
Directly on the nerve?
Directly?
No,
yeah, no.
It's not a recommendation because we don't know. First, we don't know if it's toxic, and second, we don't know if it's any helpful for pain control.
Okay. And what is the level of Acupan with WU classification?
It's considered as a first stage analgesia because it's a non-opioid analgesic.
Thank you. And a question to Professor Leboeuf and to Professor Fletcher about postoperative or intraoperative pain management in cardiac surgery. Professor Leboeuf. You introduce Acupan.
It's a difficult question because my practice is not cardiovascular surgery. Dominique mentioned, we have to be careful with the risk of tachycardia in this patient, and so this is the main caution that we have with this agent. This is the problematic of tachycardia. And perhaps, as mentioned Dominique, this is a way to administrate nefopam. In my practice, I prefer continuous intravenous infusion because I feel that the side effect is less when we administer nefopam in bolus. Because the nurse to control 30-minute administration of nefopam we cannot control that exactly.
Yes.
And so if this administration is too speed, we have adverse events. So in order to control this problematic, we prefer continuous intravenous infusion of nefopam.
Okay, you agree?
Yeah, I agree.
Of course,
Yeah.
of course. A question about non-pharmacological techniques in multimodal analgesia. Do you use acupuncture or hypnosis?
We use hypnosis, but it's another way to communicate with the patient. It's communication hypnosis rather than the real hypnosis. So I think that it's a sort of hypnosis is to inform the patient, is to communicate differently with the patient, and so it's a sort of reassurance for the patient, and this is quite better for patient with anxiety or eventually this vulnerable patients that we have to be careful. I don't have any experience regarding acupuncture in my unit.
Thank you very much. Two crucial questions. In case of patients with tachycardia, how do you manage?
Basically, you stop the infusion.
Of course.
I've never had to control it differently. I mean, in my clinical practice, I never had such a severe tachycardia that I was to introduce something or abnormal rhythm. Potentially, there's been described some severe tachycardia with some clinical impact. For example, for people with coronary disease, if you have this type of clinical symptoms, you have to prescribe medication for the cardiac problem.
And second question, do you combine nefopam and tramadol?
Why not? I mean, it's a good idea. Tramadol is a sort of two-in-one drug because you have the opioid action and the non-opioid action. And if you add nefopam, you can have a sort of three drugs together, which is good.
Okay. And anti-hyperalgesia effect of nefopam, is this effect similar as the effect of ketamine?
No, probably lower because the data are different. I mean, ketamine has shown anti-hyperalgesic effect is much more study, and it's been showing also some impact on chronic pain after surgery, and that's not the case for nefopam. Nefopam has shown only clinical impact on hyperalgesia measured in patients, like shown for the study of Philippe Richebet,
Yes.
and has shown also a limited impact on the hyperalgesia induced by fentanyl.
Okay, another question about the decrease in chronic pain, postoperative chronic pain. And chronic pain is linked to hyperalgesia.
Yeah.
And do you think that nefopam has an effect on prevention of chronic pain?
We don't know yet. We just know that when we control acute pain as good as possible, we probably prevent the chronic pain. But specifically, the connection between Acupan and the prevention of chronic pain, there is no data on that.
Mm-hmm. Okay, and about pain management, what's your recommendation? Do you think it's necessary to apply French recommendation, or we can read American recommendation and to combine both of them to implement a strategy in France? What's your recommendation, your own recommendation?
In my unit, we use French recommendation.
Yes.
So because I think that the French recommendation give very accurate information. And finally, we have a sharing point of view between American and French guideline. But French guideline give us more information. Example, when we use ketamine, French guideline precise that it's very important to identify patient at high risk of postoperative pain.
Yes.
And so, and in some surgery also, we have to be careful. And so it's very important in our practice to identify the very higher risk of postoperative pain. I think that's the real message of my presentation. So you have to identify the patient at high risk of postoperative pain intensity, and with this link with the chronic pain. And so you have to adapt your strategy in order to control the pain of this patient. So this is a very important message.
This is a concept of vulnerability.
Yes, exactly. Anxiety, depressive patient, catastrophic patient. This is very important to select this patient. And finally, this is this patient that we have in chronic pain also.
Absolutely.
So perioperative procedure with such patient, we have to adapt our analgesic strategy.
Excellent. Professor Fletcher, can we use nefopam in case of hypertension?
I would say yes,
Yeah.
because the main issue is tachycardia. I think one good way, at least in my clinical practice, to test the tolerability of nefopam is the first injection. Because
Yes.
when you administer the first injection in an anesthetized patient, you can detect quite rapidly and with a secure environment the tachycardia. If the patient has already tachycardia with the first injection during anesthesia, probably you have to stop the administration for Acupan.
You recommend infusion over 20 minutes or?
Yeah, 30 minutes at least
Yes.
during surgery. So you obtain this 1 hour delay compared to the time of administration and the time of recovery.
Okay, thank you very much. Now time's up, session is over. Just to ensure that we can work best with you for future meetings, please answer the following question, 4 small questions, and wait a short time to get this questionnaire. And I wish to express my gratitude to the organizers of the session, focus on postoperative pain, and Acupan's Biocodex company, of course. Thank you so much. Thank you, Professor Leboeuf. Thank you, Professor Fletcher. And have a nice day, have a nice evening. Excellente journée à vous, bonne soirée et à bientôt, j'espère. Au revoir.